Hello and welcome to QI Talk Time. I'm delighted to be here in Palmer's Time broadcasting QI Talk Time for you today on the Quality Improvement Toolkit. We'll be showcasing some demo tools today, and we're delighted to have Mary McKenna with us today from the AMRAP program. She's going to be talking through some hand hygiene tools. This was developed on the back of an app. When the toolkit went up live, people wanted to see the toolkit in action. So we'll be delighted to share that with you today. It will be going up on the website after. Unfortunately, we just haven't managed to get it up there yet live, but it will be something that you will be able to access after. We also have some of my colleagues here from the Quality Improvement team. So there's myself, I'm a physiotherapist by background. A lot of you who are regular QI Talk Time followers will know that this is my baby, so delighted to bring this to you today. So I'm working in the Quality Improvement team across some projects within the Sustainable QI team. We're working on the Falls and Pressurosis Collaborative, to name but a few of the projects that we're partnering with organisations. Then we have Siobhan Reynolds. So Siobhan is the co-lead for QI for Healthcare Boards, and she supports services in establishing quality and safety committees and applying the framework for improving quality. And then we have Eileen in the corner. She'll move in later on to talk to us a little bit about her section, but her main areas of interest are QI, person-centred care, and HSC values in action. She is passionate about listening to people's stories and helping them to find ways to make sustainable improvements. And lastly, as I said, we've Mary. I used to work with Mary in the Healthcare Associated Infection Programme, but now Mary is working in the newly formed National Antimicrobial Resistance and Infection Control Programme, which is very busy at the moment with everything that's happening. So we're delighted that she could give us some time today to join us. She also has a QI background and has completed the Scottish Fellowship in Quality and Patient. So we want to try and answer your queries. You are the people who are using the toolkit. So throughout the webinar, we want to try and keep it as interactive as possible. There is a chat box. So you'll see down at the bottom there's a little speech bubble, so you can click on that and type in any questions or comments or queries as they come up. We'd be delighted to answer those and address them as we go along. We want to try and keep this as informal as possible. The telephone number is there, and the chat and the event number is there as well. And also we are very active on Twitter, so if there's a room full of people watching today, if you wouldn't mind taking a picture and tweeting for us, that would be fantastic at QI Talk Time. So we're going to start with a little bit of an introduction to the toolkit. Then we're going to show you it live on the website and talk to you about how you can use the toolkit and who can help you with the toolkit as well. And then we're going to walk through some of the demo tools. We're not going to do all the tools today because we wouldn't have time for that, but we just picked some of the key tools to give you an idea how they can be filled out. And as I said, those will go up on the website after today's webinar. Without further ado, I'll hand you over to Siobhan, who's going to introduce it for us.
Hi everybody. Well, a really good place to start is around the definition of what quality is and quality improvement. In Ireland, quality is defined by the 4 domains set out by the Safer, Better Healthcare Standards as person-centred, effective, safe and better health and well-being. I suppose there's no single definition and no one approach with regard to quality improvement, but there are a number of definitions that describe quality improvement as a systematic approach that uses specific techniques to improve quality. And I suppose the most important ingredient in successful and sustained improvement is the way in which the change is introduced and implemented. So here we in Ireland, as part of the HSC framework for improving quality, have adapted a definition of quality improvement as the combined and unceasing efforts of everyone to make changes that will lead to better patient outcomes, better experienced care, and continued supported and developed staff. So I thought we would just briefly, and people might be familiar with this document, but it's a really good place to start, is the Framework for Improving Quality, which was launched around 2016. And I suppose the toolkit has come out of the work we have done as a National Quality Improvement team in relation to the framework. And what it does is really was developed to influence and guide our thinking around quality improvement. The aim was to kind of develop a common language for quality improvement. It's based on international and local improvement experience, and it's a high-level framework, But also what I like about it myself is that you can apply it to a wider organisation, but you also can apply it to an improvement project that you're doing locally. And as the document is available on our own website, but the framework really is about aligning 6 drivers, and those drivers are leadership for quality, person and family engagement, staff engagement, use of improvement methods. So the toolbox is part of this driver, driver number 4, use of improvement methods, measurement for quality, and governance for quality. I suppose the ideal is that all 6 drivers are used together when working on a quality improvement. And I'll just take you briefly through the 6 drivers. Leadership for improvement is, I suppose, the key foundation for quality improvement, about supporting, fostering a culture of continual learning and improvement. It's about creating a vision for quality, setting clear aims and objectives, and also committing some resources to QI. On the person and family engagement, it's about understanding how we partner with patients to improve services and facilitating and encouraging with different voices in relation to quality improvement. Staff engagement looks at the importance of involving staff, breaking down barriers and hierarchies, and ensuring all perspectives and ideas are taken into consideration. The measurement driver looks at building measurement into all our improvement work, sharing and displaying our measurements, making sure, I suppose, we're using measurement to show how change is an improvement. And the other thing, I suppose, is being smart about our measurement what matters. And then on the governance side of things, it's looking at the structures, the processes, and the oversight that might be in place within an organisation. So it's looking at the partnerships that might be in place, and also things like your quality improvement teams. So let's just look at the driver use of improvement methods, and really what the driver is saying is that there's a whole range of models that people can use. We use the model for improvement here in Ireland, and really the models share the same kind of underlying characteristics: understanding your problem, using the data, understanding the process that you're trying to improve, choosing tools to help you bring about change, and evaluating and measuring the impact of the change. So maybe we just have a quick look at the model for improvement. And what you'll see as part of the toolbox, the toolkit, is that the model for improvement has got 3 broad questions. Keep going there. Yeah, 3 broad questions around improvement, looking at what are we trying to accomplish, what will we know, how will we know that the change is an improvement, and what change can we make that will result in the improvement. So knowing what you need to improve, finding a way to feedback and to let you know if the improvement is happening, developing a change that you will think will result in improvement, that change, going ahead then and change. So as I said, the toolkit is you'll see parts of the model for improvement throughout the toolkit. The toolkit itself is 17 tools, is that right, Roisin? Yeah. And we use the NSI model for improvement. But what we've found with sites that we've been working with is that they brought in other tools based on other improvement methodologies. So sometimes you see lean tools being part of adaptive toolkits. So just to keep that in mind, if you have a tool out there that you think is worth using, it's good to share it with us.
And maybe just to interject there as well, Siobhan, because we have a large number of people online, we'd be interested to hear if you've used the toolkit and exactly what Siobhan said. Are there things missing, or is there any feedback that you'd like to give us? Certainly, you can type that in the chat box, or indeed Naomi will type in our email addresses that you can contact us afterwards. But certainly, get the chat box going and give us some feedback or any comments on that, because certainly it will be an adaptable toolkit. We probably will add tools to it in time. So we'll be very delighted to hear some feedback from everyone online.
And then I suppose just looking at why use a toolkit, so I think the next slide just goes into that. So I suppose what it allows you to do is to put some structure around your quality improvement work and having a standardized approach, back to that common language around quality. Helps you with gathering information, so there's things like a measurement plan, helps you document acts, so your PDSAs. It helps you organize and display information, understanding your problems. So there's a few problem-solving tools in there as well. I think there's Fishbone and the 5 Whys. and it helps to identify priority areas. We have tested the toolkit, thanks to National Rehab.
And I think they're online today,
so great.
Thanks for joining.
Yeah, so they'll see some of their own tools in there. That are the communication plan developed in the National Rehab. And I suppose there's lots of, when you're starting off, there's lots of guidance, and there's a short one-pager, an introduction with instructions to the tools. And I suppose as we're testing it, we're finding we're updating those instructions. And really, I suppose the message is it helps with small improvement projects and large scale. So I think, it's just another thing I suppose is to bring to your attention. You'll see in the toolkit we refer to level 1, level 2 and level 3 projects. And again, this came out of work we had completed in the NRH, where we felt we gathered up a lot of information around the different types of quality improvement projects that were going on in the organisation, and we felt there was a need to categorise them. So here's an example, I suppose, and we've incorporated it in the toolkit, and especially for those of you maybe who are working in very large organisations, it's a good idea to look at the categorisation around your projects or initiatives. So level 1 looks at a small maybe initiative or initiative that can be done within a department or a team. You might need a huge amount of resources. A level 2 project might be where you might be bringing a number of different departments together and you're trying to fix maybe something that's happening, a process that's happening over a number of different departments. So it might need a little more resources with regard to time, maybe some budgeting. And then a level 3 project is probably a very broad organisation-wide project that might affect every department and service within your organisation. And there's other ways of categorising projects, and plenty of examples out there, but we're using this at the moment, and it seems to be working well.
And one thing to say there on that would be that there are the 17 tools, but for level 1 projects, it might be, mostly it is the case that you don't need to do all 17 tools, depending on the size of your project. So the categorisation actually does help steer people towards what tools that they might need to use as part of their project. I know the NRH, this certainly did work for them, and alongside this, in the previous webinar, if you go to QI Talk Time, you'll see a webinar that we've done with the NRH previously where we actually elaborated a little bit more on this with respect to, alongside this, there was a register of quality improvement projects that were going on within the NRH that we tested that worked really nicely as well in terms of trying to showcase and have one place to show what improvement is actually happening at the moment, where is it at, and also I suppose it has to avoid duplication of effort across different departments. So that's just something you might want to look at alongside this if you are looking at introducing this as a method for improvement within your organisation. It is a nice talk time to go back and refer to. Thanks a million, Siobhan, for that. Siobhan is double jobbing today. She is actually delivering training elsewhere as well. So just bear with us. We're going to actually bring you now through the website itself. So just wanted to show you exactly where the toolkit is on qualityimprovement.ie. So basically, you should be now seeing the quality improvement website. So on there, if you go along, you go to National Safety Programmes. And if you go in here, you'll see the work that we're doing at the moment on the collaboratives, etc. But down below, you'll see a box here called Quality Improvement Toolkit. So if you just click on that, you'll see a nice introduction to the toolkit, and then listed along here are the 17 tools. So you will see there's tool 0 at the bottom, which is capturing patient staff perspectives. We gave that the number 0 because we feel that it doesn't really, you can do that at any stage throughout the project. The rest of them are numbered that way because we kind of felt a lot of the time, not all of the time, they fit in that order. So, but it is for you to dip in and out in terms of the tools that you use. So I'm just going to show you the introduction document. So basically this introduction document has a lot of what Siobhan has already spoke about, but it's a nice little preamble to the use of the toolkit. So if, for example, you haven't even heard about quality improvement, if you go on and read this, it will give you a nice tips and tricks and just a beginner's guide to QI. So if we go down, you'll see you have the framework, you have the levels that we talked about. We also talk here about who will help you, and Eileen, my colleague, is going to discuss that a little bit later, so we'll go into that in more detail then. We have the model for improvement, we have about aim statements and using the SMART aim. you have how will a change be an improvement, and also what changes can we make to result in improvement. You should be seeing now on your screen the 4-phase approach. This is one of the key documents. I hope you can all see this okay on the screen. So we have divided up the approach to QI for any project into 4 main phases. So the light bulb idea, the plan, the do and study, and sustain and spread. So within the light bulb idea, you'll see there we have 4 swim lanes. There's the staff member, the line manager, the board management and team, improvers, and the tools. So alongside each of the 4 phases, we've mapped on the specific tools that we think are relevant to that phase. So for example, the light bulb. So is there a problem with this transmitting, Naomi? So maybe if we go back to the slide set actually. Sorry, apologies for that. We were just trying to show you from the shared. Yeah, so the link has been shared with you there. So we'll go back to the actual, sorry about that, just broadcasting over correctly there for you. So we walked you through the website. Naomi has put that up online. So there is an introductory document. Then within the introductory document, this is what I was beginning to talk about. So you have the 4 phases, the light bulb, the plan, the do study, and sustain and spread. So basically, within each phase, you have the tools that are mapped onto each of the phases. So light bulb, plan, do study, and sustain and spread. So for example, I might come up with an idea that I want to test in my department, discuss it with my line manager. The line manager will say, yeah, fantastic idea, off you go, and then you might think about discussing it with your key stakeholders. But also, you might also be told by your line manager, do you know what, we leave that for another time. There's bigger priorities at the moment, or don't have enough resources for that. So that might just be something that you'll bank for later. So discuss it with key stakeholders. Then you might move on and do the project charter, which is the tool number 4, which goes into planning. So I'm not going to go through every step, but you'll see it does map it out for you, and it will give you a nice roadmap if you are thinking about doing a QI project, be it a small or a large project, that you can refer to this one-pager. So that's in the introductory document, and here are the tools that are listed on it. Also at the end of the introductory document, it is important to note that there is a one-pager checklist. So if you're thinking about doing a QI project, you could talk to your manager with the checklist, and they might say to you, okay, well, maybe you should focus on the project starter or the communications plan for the moment, and then come back to me when you've those done. Or it could be another QI enthusiast or a member of your team. You could just look at the toolkit list in totality and just pick off the ones that you think are the best ones to start with. So I'm going to hand over to Eileen, who's going to talk about how and who can use the toolkit.
Hi everybody. Yeah, I won't keep you too long at all. It's just really to explore how and who, as Russian said, can use the Quality Improvement Toolkit. And I suppose the short answer to that is absolutely anybody can use the Quality Improvement Toolkit. You don't need to be formally trained in QI. You don't have to have any experience in previous quality improvement work at all. In fact, my own daughter was doing a college assignment over the weekend, and she was looking for some templates for like the project on the page and the project charter, and I gave them her. She was able to adapt them and use them. So, you know, they can be used and you can adapt them. They're live documents that you can take and use. They're available in Word and PDF versions, so you can change them around to suit your own needs. I suppose, as Rasheen said earlier, you don't need to use all 17 tools. When you look at a list of 17 tools, that can be quite daunting. So, you know, start small, and I suppose we would have our top picks for QI tools. So we've listed 6 tools there that we feel are probably the ones that if you're not used to using the Toolkit, you haven't used it before, you haven't maybe been involved in a quality improvement project, that these would be the ones to certainly have a look at first and familiarise yourself with, and, you know, find your way around them. And they're the ones listed as Project on a Page, Stakeholder Map, you know, who you're going to communicate, how you're going to communicate with them, aim statement and driver diagram. That's just, you know, a must-have really, because that will keep you focused. It'll keep you in the right lane as to what you intend to do, how you're going to do it, and what you need to have in place to achieve what you have in your aim statement. Project charter, again, all of these are on one page, so they're not cumbersome, big, huge documents. They're going to take ages to fill out. That's just setting out, you know, what, the who, the how, you know, it's just a more well-defined piece. Communication plan, absolutely essential as well, to identify from your stakeholders, how are you going to communicate with each of those stakeholders, what's their preferred method of communication. You'll know the people in your organisation or on your unit or your ward or your department, how they like to be communicated with and what's best and what message do you need to be delivering to them so that they can influence and help support you with your project. And then tool 12 is plan, do, study, act, or a PDA Cycle. Some people can have a little bit of, you know, uncertainty around these, but just follow it through. It's common sense. It's nothing more than common sense. None of this is rocket science. There's none of us here rocket scientists. You know, it's common sense. QI is common sense. The other top tips we would have is to speak to as many people as possible about your idea. You know, throw it out there, see what comes back. You and the people that you work with and the people that receive the service that you deliver, you are the subject matter experts. I can't come into anybody else's department and say, you know, you should think about changing that and changing this and doing this and that. I don't know your service as well as you do. You are the expert in your field, and you will already know what things can make a difference. Please, you know, don't forget about the people that actually receive the service, or their relatives, or, you know, their advocates, whatever. You know, bounce your ideas off them. They will have such rich information for you. It's unbelievable. Find like-minded people to work with you. As we always say, you know, we don't take hostages and we don't carry passengers. You just don't have the time, the space, the energy for that. Work with the willing. Work with people that want to change as much as you do. So they're the like-minded people. They're going to make everything so much easier. If you're all, you know, may not always be on the same page, we'll have your disagreements, but they're willing to work with you. And that's really about conversation, 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 conversation. Every second person you meet, tell them about your idea, what do you think of this idea? You know, pitch it all the time. You'll get some really good information back. Learn from others. You know, try and find out, is there anybody in your organisation that has done something similar, either on another unit, another ward, another department? Do you know somebody in another organisation that has done something pretty similar? You know, learn from them. You don't have to start from the very beginning again. You know, as I say, share, or as some people say, steal unashamedly, but steal with permission. So stealing with permission is sharing. And, you know, try and find as many people as you can that have done similar stuff. It really does make life easier, and that kind of just builds that community. And we'll be talking about community of improvers in the next slide, I think. And then when you've kind of got all this information, commit it to paper on the tools there that we've talked about, because ideas are great, but unless you commit them to some kind of structure, they just remain ideas. They don't kind of evolve into plans, and plans are what you need. So the next piece is, stick it on there, around who will help me with the use of the toolkit. But as I said earlier, you don't need to be formally trained in QI to use the toolkit or to embark on any kind of small, quality improvement project. You can get started by reading the introduction to the QI toolkit. As Roisin said, it's really good. Try and connect with others, as I've said, in your unit, your organisation. Places like Twitter, LinkedIn, use all those social media things. I have to give a shout out to CUH Improvers, because they were tweeting about a different tool in the toolkit all for the month of February, so thank you very much. Find out, is there a QI lead in your organisation? Is there somebody in your organisation who has received quality improvement training? Is there a community of improvers that you can connect with? This slide here really is for QI facilitators and line managers. Encourage your staff to use the toolkit. It's there. It's a great resource. Please use it. And as Roisin said earlier, come back to us with feedback. If you find something is not as user-friendly as it should be, or you feel you have a template that is even better than what we have, we're all about QI. We want to improve what we have. So we're really, really, really asking for you to come back with that feedback. This is just really coming back over the other things. Select the number of tools relevant to the size of your project, create opportunities to bring staff together, share your learning for projects, and initiatives, and celebrate. And we were having this discussion yesterday. Make the celebration special. Make it visible. Don't just leave it to be, a poster or a report or sending around an email saying everybody did great. Have a hoolie. Have cake. Have balloons. Make it visible. Try and integrate the whole ethos and thought of QI from the very beginning. At induction. And we were talking about this again this morning around, it should be like your health and safety training and your occupational health training. All of those, QI, that's where it should be. Introduce those conversations. Support sustainability as much as you can. As managers, we need to be kind of thinking almost from the conception of ideas, how am I going to sustain this and how am I going to spread it? And use the checklist with staff. The last one is around overcoming obstacles, and these would be a lot of the pieces that we would hear continually. I don't have any QI training. We've already said, you don't need it. Anybody can do this. I don't have the authority. Okay, you may not have the authority to do a whole hospital-wide piece or a whole outpatient clinic or a residential unit piece, but you can start and work on your ward. Work on what you can change. Small changes can have a huge, huge impact. And I don't have the time. Nobody has the time, but don't work alone. That's why you need to be bringing in as many like-minded people to work with you. Bring them along and share out the load.
And it probably would be true to say, Eileen, that the toolkit answers these obstacles because it gives people a method. And it also, because there's a method there, you'd hope that you'd make up on time because you're following, a tried and tested evidence-based process. So absolutely, the toolkit is the solution.
So that's me. Thank you. I'm going to let Mary in.
Fantastic. Thanks a million, Eileen, for that. Now we get to the crux of it, the hand hygiene demo toolkit. So we've been working with Mary McKenna, who's an IPCN nurse on the AMRAP programme, and very busy at the moment with everything to do with the recent virus that has hit us. So thanks for Mary for coming and giving us some time. So we've actually completed all tools within the toolkit, just doing some final refinement, and that will be available up on the website for people to use. So we think it would be a nice resource for people to be able to click in and get some ideas and see how it flows from tool 1 to tool 17. So I'll hand over to Mary. She's going to just give us a highlight of 4 tools. We just picked 4 to showcase today, and as I said, the rest of the tools will be on the lineup.
Good afternoon, and thanks very much, Roisin, for that very rich introduction. And as Roisin said, and Eileen and Siobhan earlier, it's really about putting structure to probably work that you're already doing to make changes that are improvement, but this toolkit actually gives you structure. So we're going to focus on, I suppose, some of the key things that I found were helpful. Before I came into QA, I was massive about change, but which is why I embrace the fellowship and the ethos around it, because believe it or not, on a day-to-day basis, once you get the toolkit into your head, you're actually making changes happen in your day-to-day job. But take structure back to this project on a page, which is a really nice starting point, because really you want to get something down, put some structure to ideas and thoughts about what you're doing. So I suppose the project on a page really is about actually identifying what is it that I want to change, and how am I going to do it. So you're trying to get some high-level thoughts and ideas in relation to the project, and kind of process mapping it in your own thoughts, and then coming to maybe your line manager or a colleague even at work that maybe is like-minded, as Eileen referred to, someone that actually gets it when it comes to making change happen and can see the positive side of change and improvement happening. And we've seen massive examples across the health system where fabulous work has been done. For the purposes of this, I'm referring to, using a hand hygiene program. I suppose it's very timely in line with coronavirus that we're talking about hand hygiene, because it's a change idea that you may all want to adopt. But certainly, you do need to have, as Eileen said, you can't work on your own with all of these things. There's no I in the team. Okay, it's about working together, and evidence more and more so contemporary is saying that the more people work together, the more change will happen, and the more productivity there is, because you're sharing ideas and you're bringing that engagement and people on board. But you do need to have, obviously, some project leads, so someone that's going to actually be drivers of what's happening. I suppose putting structure on, you're looking at your aim. You have to have an aim. It is really important. Regardless of how small or how big your project is, you need to look at what it is that you want to do to make an improvement. And I suppose it's good that we're using the structure of the SMART, so you're being specific. Very important to be measurable, because we need to know, is there going to be an outcome that is actionable, achievable, and that it's relevant within a time frame. Like, there's no point in saying I'm going to introduce a hand hygiene program in 2 weeks' time. That's not going to happen. So you have to kind of use the process and the structure with your model for improvement to actually bring you into a sort of a timeline of making the changes that will happen. So I suppose with the project on the page, you're looking at how will you actually know that a change is going to make an improvement. So you're going to gather and report on different types of measures. That if I am going to introduce an improvement project on hand hygiene, how am I going to know that it's going to work? So you're looking at maybe what program am I going to introduce. So you invite maybe and support staff to become, for example, one of our very recent initiatives is there is this program where we have train the trainers in the community, and it's now kicking off in the hospital setting. You have, you're bringing it back to the ethos of patient safety, patient care, but you're bringing local improvement. So it's no longer the IPCN coming to teach the 5 moments. I know when I was an IPCN and when I came to the ward, people thought I was the 6th moment in hand hygiene, to clean their hands. This is about normalising good practice, using the structure of QI. So to get people on board to do that, you invite and support staff maybe to become local hand hygiene trainers and attend a 1-day program. So that's something that that could be a measure. And then have your hand hygiene trainers, they will deliver the education locally. So they're going to have a standardized toolkit to use of materials for hand hygiene, for example. And then you'll have promotional materials to promote the hand hygiene behaviour in the workplace. And then making sure that everything's in order, like you have to have your facilities in order, so there's access to your alcohol gels and your sinks. Also about keeping hand hygiene and proper glove use on a priority agenda. So by having your local trainers as champions, they're going to bring that in. And then taking it back to the patient, is this improving satisfaction and compliance with patient safety? So, are all already available HSE patient surveys, maybe undertake a patient satisfaction survey to include hand hygiene feedback from the patients. And I've recently been involved as a patient in actually completing one of those surveys. And I have to say, from a patient's perspective, it's actually really good to be part of this, because you feel that you have a contribution to make and that your voice is going to be heard. So I would say that is key as well. So always think about the patient when you're looking at measures, because it's not going to make an impact to the patient's safety, patient's confidence in the care that they're getting. You're probably losing out a little bit of value in terms of the quality of the measurement.
And the other thing, Mary, maybe to say as well, it's not about the number of measures. You might look at this and go, oh God, how would we ever? This project on a page is about brain dumping everything down that you can think of in relation to improving hand hygiene. So we've lots of ideas here and lots of ideas of how we might measure, but it's not to say that you're going to do all of it straight away. You'll pick one and start.
Absolutely. Keep it small and as you said, Roisin, keeping it within the process. But it was just to kind of, looking at your measures. Then you have maybe, I suppose, your auditing as well. What it is that I'm going to, I suppose, count or see is going to make a difference. So maybe the number of staff that are actually going to be trained as trainers, and the number of sessions that they can then go off and deliver. And then that's the percentage of staff that are actually trained in hand hygiene. So you're getting pretty good out, and that's good information that management like to see as well. So you'll have your buy-in there. And then looking at again, back to the patient, a number of times when a hand hygiene moment was performed, and the opportunities to perform it, versus if it didn't happen. And then I suppose your audit of compliance and your assessments, again, your satisfaction survey and your accessibility to your gels and your hand wipings. And that's bringing you on then to looking at your outcomes, like what is the impact or the results for the service. So, what is actually going to happen here? Now, these are just suggested drafts on this template, but, you know, if we're going to have a reduced rate of C. diff, or staph aureus line infections, use clinical jargon on that, but actually, is it making a difference? And that may have drove your idea to bring hand hygiene in the first place. There was a high risk of maybe internal transmission in the workplace. Mortality rates, a significant concern for management. So it's always good to look at outcomes that will bring management on board, because you're looking at the organisational improvement as well as your local improvement. But back to your local, your percentage of staff knowledge of the 5 moments and their compliance with maybe bearing the wrist or bear below the elbow policy. They've all got their local trainers and their education, so the champions there. Is this making an improvement? Can we measure it by the volume of alcohol gel? Has it gone up? And so those are some of the suggested examples. But then there's also what is known as balancing measures. So these are things that can put the cat among the pigeons, for the want of a better way of saying it. Was there unexpected or adverse, you know, sort of scenarios that have occurred that may impede on what you thought you had this nice program mapped out? So some of the things that can put a spanner in the works would be maybe an outbreak of infection. Now that should increase the hand hygiene indications, and it will increase your resources. So you'll see things moving up. You'll increase the staff maybe using your gloves and the associated costs. So you have to. It's really important that you have that balancing measure, because otherwise you could say, well, it's more expensive now. We're using more gloves than ever since we introduced this. So it's knowing what them outliers are, and then looking at your staffing levels. You know, if you're really, really depleted in staff levels, evidence is that we have a lower compliance with our 5 moments because it's taken longer time to perform tasks. So these are things that always be cognizant about, whatever your project is. Looking at, yes, this is what my aim is, these is what my measures, my outcomes are, but my balancing measures are important, because that can have a sort of a time and place, I suppose, to be a source of a challenge to what it is. And don't let that put you off. It's just always important to acknowledge it. Okay, we're going to move on then, and we're going to look at I suppose I was just talking there, the example about the changes, yeah, that we can make an improvement. So what am I going to do that's actually going to make an improvement? You know, and we will talk about the PDSA in a moment, but I suppose it comes part and parcel of that. You know, we're going to train and support staff to be auditors, and they're going to be our champions in the workplace, and they're going to teach other people, and then the results will be fed back to the ward management and staff of audits of improvement on a monthly basis. As I say, this is really just a suggested template. This is not how another IPCN will do things. This is just, it's really up here as an example. Introducing, we have a RESIST program, which is actually, RESIST really is a promotional, thanks Russian for pulling that up. It's a campaign of promoting good practice to prevent healthcare associated infection. And hand hygiene trainer programs are a very strong arm in that. So they have a whole suite of materials and information leaflets that can be introduced. So you may be introducing change, but you know, I know Eileen talked earlier there about pinching with, I say pinch with pride, but not actually pinching, you're actually using and embedding good practice information to make your PDSA and your plan of action work, and having your results then compiled, bringing it to your infection control committee as well to your local staff, because we know that more than often staff do not see the changes. So what's in it for me? If they see the benefits and they feel they're going to be part of the future celebration of this, you're more likely to have the buy-in.
And I see a question coming in from Valerie, and she's coming saying it's great to see a completed tool, great detail in the range of measures on the project on the page. So yeah, I think the project on the page just allows you to throw everything down, and you can refine further with the project charter when it gets to that point. But another question Valerie has is, we mentioned Mary there about getting the patient perspective. So how is it best to measure patient engagement by increased patient assistance in delivery of care? And actually, Valerie, I think, you know, if you look at the tool 0, capturing patient and staff perspective, there's a raft of different ideas there in terms of collecting that. So there's qualitative and quantitative ways, but mostly this alludes to qualitative. So if you wanted to refer to the tool 0, it gives you a nice like surveys, bringing groups of people together for conversation in a group. It talks a little bit about the analysis of the data, So it can be structured and unstructured as well. But it is that piece of ticking the box, but having real valuable patient engagement through survey or focus group, whatever it is. But Tool Zero is excellent to refer to.
Okay. So one of the other tools that, out of those 17 that we're going to use as an example, is the Stakeholder Map. And that's really, you know, you're implementing your program using QA methodology here, but you need to look and see now, you're going to map this out. So you're putting some structure in what it is you're going to do. And one of the nice tables that they have included in the toolkit is having a level of influence of, you know, for success. So within that, it's important to know who's your winners and who's your laggards, for the want of better words. So who would be resistant to change? Now, be cognizant, it's important to have the right people on your side for certain projects. Like, there's no point in saying I'm going to introduce a change program where it's completely unwanted and people are quite resistant to it. So always think about it in time and place. But having people on board, so you have different levels of your influence, so you have low, medium and high. So like I had put, if I had my CEO as high on the resistance, I would really need to get him over onto the supportive side, not just neutral, because if you're going to introduce something, you're going to want the buy-in, and that's why I'm saying, going back to your measures about including your organisational high level a little bit. It doesn't have to be all, but just to kind of to let the CEO feel that it's part of the management agenda, that you're going to drive safety at all levels within the organisation. So that's just a suggested example.
And another thing to say on that as well would be people can move throughout the project. So you might come back and re-look at this and reevaluate. So you might be a month in and one of the consultants might be really jumping on the bandwagon and move up to both the high and the level of influence for success, because they're really championing forward on the management team level, and also the supportive side of things as well. So, you know, people change, the mapping will change throughout the project. So that's important to note. So it is a trigger then to think about, oh, well, there's a group of people that I need to really think about and plan my communication and try to pull them in and move them on the stakeholder,
And I suppose I'm going to take a minute just to say, Roisin, that is so important. And you may say, well, how do you actually do that? Because they're sitting on the resistance side of it. And I'm just going to throw over one example. It's not hand hygiene, but a few years back I was involved in small-scale testing of a stop campaign to reduce the number of PVCs that were being inserted in an ED. And when I first went to the ED consultant, he would say himself he didn't want to know. But we actually got some background measurement on of the number of lines that were being inserted versus those being used. And when we brought that data back to our ED consultant, who was sitting on the resistance side, okay, the data was brow-raising, and he really wanted change. So he felt part of the problem or the issue that needed change. That consultant went on to be the key driver of the program, and the number of lines that went in went from 71% to 19% within a short space of time. Very little activity, but having that influence. So, pardon me for coming in on a different one, but the example stands to mind that if you have resistance, as Roisin said, to bring it across the line, having some baseline data to highlight the problem and a little bit about what's in it for me can be very influential for the low-hanging fruit or the quick win, as you're actually saying there, Eileen. So I suppose then we're moving on to your aim statement and your driver diagram. So that's to kind of help drive the path of an improvement project by providing a really visual representation across your improvement theory. And I have to confess, before I went into QA, I wasn't one for the theory. I wanted things to happen on the ground. And I had to be kind of rode into the structure of QA so that what I was actually doing on the ground, you were actually doing it more effectively by having your QA process. And it's really great to have these toolkits to kind of support us all in doing that now. But as I said before, having your aim statement really smart, and I suppose within your driver diagram, and it's really like a roadmap to kind of take you from what your aim is to how you're going to make some changes happen. So what are your drivers? What do you need to make this happen? What are the primary things? So this must be present, to achieve, and that's really paramount as your primary one. So here we have, some of our measures could be the number of indications where a WHO hand hygiene moment is required. That's where the hand hygiene is actually being performed. Access again to facilities and your number of staff that are trained. But to actually bring any program, which is, forget about the technical side of the hand hygiene, to bring any program into life, you need to have, within your primary drivers, we would have identified leadership commitment, because that's going to drive support, and it takes that fixed moment away from the infection control nurse. We look at the hand hygiene program. What is this program going to be? So is it going to drive the change improvement? You may have other very small scale ideas. It could be one thing that you're going to change. But if it's going to be paramount in actually making patients safer, making your service better, really useful. And then looking at your staff, what's my staff engagement? Who are going to be part of my patient engagement? How is that going to happen? And what will my improvement method be? Then you're going to actually look at your secondary drivers. You're going to move across then and say, what must be present to drive? Okay? So some people will say maybe you might need a medical forum or a nurse management forum or a train the trainer program, a patient information and feedback, or staff education. So some of these may seem a little bit small on here, but you'll see them when we divvy up the toolkit and it's on the website. And then the biggest part is that everybody wants us to change ideas. You have a lot of collaboration going on, so I'm here with Eileen and Roisin, and we're going to throw out this webinar. What are ideas? But through collaboration, different ideas, and I think, I don't know why she wants that, because I'd like this. But you negotiate the ideas because you want to get a common ground. So it's important to acknowledge people's ideas. Okay? Some of them may seem a little bit off the radar, but you can, I had to be wrote in, so I'm very conscious that my ideas could have been very wacky at times. But when you bring it in line with your aim and your drivers, and get people to work within your structure, you'll find that your driver diagram becomes more meaningful. So some of our, what do we have here, Russian? So we have about having a resist program, about
deliver the training workshop.
So it's like a process of ideas that will make this all happen. But bringing in your primary drivers and your secondary drivers, these are my ideas, and they will map into. And really what this driver diagram is about is actually having a sort of a template so you don't really miss anything really, really important. It's giving you structure, because you could present this lovely driver diagram and say, I'm going to run this project, and then realize, you haven't got any leadership commitment. What action am I going to take? What are my change ideas here? So it's, it may be about measuring that and bringing it to leadership to highlight a problem or to highlight an issue or a cost analysis, a benefit of some description. So those are just some suggested examples within the driver diagram.
Yeah, and you might see there that some of the boxes have multiple arrows. So just to say, it might help you then to prioritise what change idea you're going to look at. Because say one change idea might deliver on 3 or 4 primary drivers, so you might translate it back into that, so you kind of go, okay, well, if we did that one, that might be the biggest bang for our buck. But obviously you have to evaluate the amount of work and resources and everything needed. But it's a nice visual way to represent that and have that conversation with your team around where you're going to focus your energies in the first instance. Yeah.
And your driver diagram may change. You may have put on these change ideas, and when you go on to test a few, you may come back and say, well, actually, I have got some more ideas that would be more productive here. So it's never all set in stone. Okay, so then we're moving on finally to one of my big favourites is the PDA Cycle. The reason why I say that is, as I say, back in the day before I came into QI, Russians often heard me saying that my language was PDSA. It wasn't plan, do, study, act. It was please do something, anything. So I'd be running around ragged trying to do a number of things to make things better, but I didn't really have a structure around it. So, your planning, doing, studying, acting is really, it really is the ethos of actually understanding and seeing how change will happen. So you're planning, implementing the change, what is it? So it may not be you that's going to implement the change, but it's getting somebody else, going back to your driver diagram. Maybe if you have your leadership buy-in, so you have your senior management, you're supporting them to invite nominations, they become hand hygiene resist champions. In the workplace, they undertake the trainer program. and you're giving them your dates, so you have what, you're implementing that change, who, it'll be your senior management, and there'll be a timeline, where it will happen, and how it will happen. So, you know, it's really good to kind of just, again, you can put your change ideas into this as well as part of PDA Cycle, but actually having it within a timeline, you're planning, you're doing, you're studying, and then you're acting. So you're going to communicate that change and the test. So who's going to communicate it, by when, by where, and how. And again, your trainers are going to pitch up at the workshop on the 10th of March. And because coronavirus is on the horizon, everybody wants to clean their hands and do it properly. So we definitely will make sure that that change will happen. So that's probably back to our balancing measure. We could actually say in the context of the coronavirus is a balancing measure because it's influenced and maybe improved behaviour, which is really what we want in the QA is behaviour change. Documenting the implementation of the change, you know, so who's going to do it and by when and where. So what it is that you're going to document, who, and you know, what is it that's going to be documented? So maybe attendance records, a number of education sessions, and measure the improvement indicators. So who's going to do it? You know, it could be all of the project team, or it could be somebody nominated on behalf of the team. Picking a realistic timeline, again, be realistic. So this is back to your planning, that you're going to have a realistic timeline across maybe all your wards and units or whatever. And evaluating the effect of the change. Did anything happen? You know, and again, who, bring it back maybe to your senior management. Have they noticed anything? Maybe the audit results are looking better. And when? So when's a good time to actually do this? And where am I going to go to pitch this and how? So you're maybe analysing, for example, the patient satisfaction survey. And bringing that feedback is always very encouraging to staff and patients when they see that, you know, there's change that is positive and it's an improvement from what it previously was, or your observational hand hygiene audit results. Okay, so in terms of your plan, doing, study and acting, I'm not sure if I have another slide on that, Rush. I think that I could do it. It's, you know, you're planning what you're going to do. So I'm going to improve something. This is how I'm going to do it. You know, and by when and who. So we know who our stakeholders are. And then we're going to study and reflect on it and see, you know, what has actually happened here, or is there changes that need to be made, more change ideas needed to make this better, and then, you know, you're acting, you know, so you're taking action.
Okay, thanks so much, Mary. That was fantastic, and I think it's so pertinent in today and over the next while. It's a nice example for us to have. So we will have that hopefully up online, a completed toolkit. But I think it's one as well that notwithstanding Corona, but we all should know something about. So that's why we chose that as an example, because everybody can relate to it. So I don't see any other questions coming in, Mary. Thank you for the tweets. We see you H in the room, so so that's fantastic. And Valerie from the NRH, thank you so much for all your contributions as well. So just there is some more time if you have any further questions on that. But just to say as well, we didn't mention actually tool number 10, the measurement plan, which probably, you know, would be one of the more important ones as well. We did talk a lot about measures there. So this tool, it will pick off the measures that we spoke about and really drill down into how you collect them, when you collect them, how you're going to display them, who you want to influence with the data, where is it going to go to, all of those things. So have a look at tool number 10 as well. I think that should trigger some questions with you with respect to measurement. Questions coming in there. So we'll just go on to this last slide. So thanks to our colleague Michael Carter who put this together. It's a really nice one-pager, and it's actually up online at the bottom of the toolkit. So this, again, is a lovely, I suppose if you were thinking about improvement, print this out, put it up on your desk or on your notice board in your apartment. It's a really nice way. So if you go to the left, you've got a light bulb moment, you've got an idea. What should you do first? Those 3-4 things there. So you should listen to subject matter experts, look at the data. So what data do you have there? How do you know there is a problem? Comparing it with your service against regulatory standards, so the HICPA standards are always that are good to look at. Learning from evidence and experience, so all of us who are clinicians would keep up to date with the most recent evidence-based practice. So that's going to tie into your change ideas. Once you have an idea, you move along here to the dartboard, and we have a name. So the aim, as Mary talked about, was specific measurables achievement time bound. So once you have that aim agreed, you can then progress on to the driver diagram, as we talked about earlier. And then out of that will fall your PDSA. So you're testing your small tested change that can be based on your change ideas. So you're documenting those all the time through that template, and all the learnings that you're having will transfer into the next PDSA, the next test. An ongoing cyclical thing. So how do you know a change is an improvement? So that's that measurement tool that I talked about. There's also lots of other tools up on the measurement improvement website on qualityimprovement.ie, where you can find run chart templates, these run chart rules, all of that. So you'll find that up on qualityimprovement.ie on the measurement section. And as we said throughout this, remember, it is okay to change direction. Learn from your improvement work. So we're visiting your aim statement, we're visiting your stakeholder map, your driver diagram. It is going to evolve over time. So always remember that that's okay. So yeah, so that's just a nice summary for to finish off on. So I think that's it for today. We've just had a few thank yous, but no other questions. But thank you very much for joining. Hope that it's been helpful. As I said, the toolkit will be up hopefully within the next week online, so you'll have access to the whole toolkit completed. And thanks so much for Mary for her time today and helping to give some that back to you. So hopefully it will be of use. So also we'd like to reference the Institute for Healthcare Improvement, IHI, is a lot of their tools. We've taken them and adapted them, so we'd like to reference those and all. So just to say as well, before we finish, the next QI Talk Time is Tuesday week, and it's on the No Check Ask campaign. So it's on the BTE medication safety. So it'll be Ciara Kirk and Muriel Tate from medication safety who are going to dig into that. So the alert cards that they're introducing. So we'll be looking forward to that. So the notification will be going out next week on that. Thanks very much for joining, and look forward to seeing you in 2 weeks' time. Thank you.
Thank you. Bye.